The NCCN guidelines for relapsed refractory mantle cell lymphoma divide the approach actually in looking at how good of a remission patients got with their initial therapy. So if patients got what they identify as a good remission with their initial therapy, which is about expected, what the median PFS, progression-free survival, is expected with that therapy, then they list more options than if patients had a poor response or a poor remission duration to their initial therapy. And the patients who relapse early or have a poor remission, they really recommend approach with one of the targeted therapies and not reusing chemotherapy. There are a number of targeted therapies, including there is now 3 oral BTK inhibitors approved, ibrutinib, acalabrutinib, and most recently in November of 2019, zanubrutinib was approved for relapsed refractory mantle cell lymphoma. Rituximab and lenalidomide, which is an oral immunomodulatory agent, rituximab and the proteasome inhibitor bortezomib, or also listed in the NCCN guidelines is venetoclax, which is an oral BCL2 inhibitor, which has high response rates in progression-free survival similar to the BTK inhibitors, although this is in the guidelines but is not FDA approved at this time as a treatment for mantle cell lymphoma. For patients who achieve prolonged remission durations to their initial therapy, be that any chemotherapy approach, it is recommended that option would also be to repeat chemotherapy depending on the initial treatment. So if somebody has received R-CHOP or a more aggressive intensive regimen, bendamustine rituximab is a reasonable option if they achieved a prolonged remission duration with that therapy, or using R-CHOP in a patient who's received previous bendamustine rituximab. And again, all those oral non-chemotherapy approaches with those targeted agents is also listed in the NCCN guidelines for patients with prolonged remission duration. When trying to decide second-line treatment for a patient, at this time, I think that an oral BTK inhibitor is an appropriate approach to any patient. They have high overall response rates, they have reasonable complete remissions, and they have good progression-free survival. This looks especially good when it's used as the initial therapy at first relapse. So in the majority of patients, my choice is going to be an oral BTK inhibitor regardless of remission duration. Although I will say that these therapies at this time are, once they're started, they're continued as long as a patient is tolerating and responding. So they are somewhat indefinite in that situation. So there is a handful of patients who's maybe had a prolonged remission duration to chemotherapy, where I'm looking at not wanting them to have to be on a therapy forever, or cost maybe is an issue. And then maybe that's a patient who I'll go ahead and repeat a less intensive chemotherapy approach in. But for a large number of patients, I think a single agent BTK inhibitor or in a trial with a BTK inhibitor in combination is the preferred treatment of choice.